Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sakia. Today, I'm joined by Dr. Nicholas Leeper, a board-certified cardiologist specializing in the care of patients with atherosclerotic cardiovascular diseases. Nicholas is a professor, chief of vascular medicine, and director of vascular research at the magnificent Stanford University in California, USA. And he tells me the weather there is lovely. It's actually nice here in London. Nicholas earned his undergraduate degree, a bachelor's in chemistry, and his medical degree from the University of Chicago. He completed his internal medicine training at the University of California, San Francisco, before pursuing fellowships in cardiovascular disease and vascular medicine at Stanford. Nicholas has produced an impressive collection of peer-reviewed publications and is actively engaged with the Society of Vascular Medicine, the Gordon Research Conferences, and the American Society for Clinical Investigation. He's also held multiple roles with American Heart Association. The good doctor leads a translational laboratory focused on leveraging human genetics and advanced immunology approaches to discover new cardiovascular therapeutics. He's also the co-founder of two biotechnology companies, 47 Inc. and Bitterroot Bio, which aims to prevent cancer and cardiovascular disease, of course, the world's two leading killers. When Nicholas isn't busy with work, he enjoys sport, golf in particular, so he's a masochist, I guess, and spending time with his family. Professor Nicholas Leeper, it's an honor and a pleasure to have you here with us today at the EMJ podcast.
Jonathan, thank you so much for having me.
You're welcome. Forgive my comment about golf. I've tried to play golf twice in my life. The second time I was playing with a lovely group of friends, all of whom were being really sweet to me and trying to give me advice. So much advice, my head was exploding until one of the guys came up and whispered in my ear and he said, "Jonathan, don't worry. I've spotted what you're doing wrong." And he paused for dramatic effect and said, "You're standing too close to the ball after you've hit it," which nailed it for me. But anyway, so share with us your journey from studying chemistry to becoming a prominent figure in cardiovascular medicine. How did that all happen?
Sure. My scientific journey began quite early. I come from a family of scientists and physicians, and actually I'd worked in a research laboratory in high school. I had dropped out of high school, as a matter of fact, to attend the University of Chicago, where I began studying chemistry, really being enamored by the quantitative sciences there and the ability to find truth through mathematics. But I also began to work in human genetics at that time, and really had a lot of enjoyment working on rare diseases and trying to help these families who were afflicted by these really devastating conditions. But over time, I realized that I wanted to have a larger impact and move away from rare disorders, and decided to go into cardiology, which, as you mentioned, is the leading killer in the world. I was fortunate to come through my postdoc training at the time when the Human Genome Project had been completed, and we were able to, really approach these problems through a new lens. And the rest is history. I've had a lot of fun trying to have an impact, really working beyond the established risk factors that we've known about, and how do we advance the field beyond cholesterol and blood pressure and diabetes. And I've had a really enjoyable career so far trying to bring new therapies to patients suffering from heart attack and stroke.
When I think about, and I talk about it often with my cronies from medical school, about how medicine has changed so dramatically during my professional lifetime. There's an old aphorism that within 5 years, you will discover that 50% of what you learned at med school is wrong. And of course, I've been qualified so long, I don't think anything I learned is right. Anatomy has remained pretty much the same. But given that medicine's changed so much and the pace of change is advancing in exponential fashion, during your career thus far, and you're just in the early stages, what are the most exciting advances you've witnessed in the field of cardiovascular research, and like I say, during your career, during recent years, and what do you think the future holds?
Well, I think there's really been a groundswell that's been enabled by both, technological advances, kind of a change in the posture about how people collaborate across universities and in the field in its entirety, and the deployment of kind of unbiased research that's opened up new avenues that really wouldn't have been possible, 1 or 2 decades ago. So, what do I mean by that? Well, the tools that we have today in the toolbox are just exceptional. And, the ability to make induced pluripotent stem cells as research tools, use these new, wonderful genome editing technologies as a way to test hypotheses and look at the effect of individual genes, or the deployment of artificial intelligence and machine learning to analyze large data sets and see patterns that couldn't have been seen before. This has really been, a way to allow us to stand on a step stool and much more powerfully approach problems than we ever could have before. I think the second thing that's changed is this concept that before everybody had their own samples and they had their freezer full of their own patients' biobank tissues or blood or whatever, and they would kind of hoard it almost. And with the advent of these large genetic consortiums, we saw this investment in infrastructure, like the UK Biobank, for example, where they said, we're going to do genome sequencing on 500,000 individuals and link that with the EHR and then make it publicly available for any qualified investigator to ask questions. I mean, this was an incredible gift to our field and has allowed us to all come together and say, I have this idea, I have this hypothesis, let's test them in a way that would never have been possible when each person was working on their own silo. And then the final thing is just the approach about moving from hypothesis driven research to one where we say, I actually don't know what truth may be out there. And so I'm going to look in an unbiased fashion across the genome. And this is where we're starting to have these great surprises about genes or pathways that are relevant to all types of disorders that probably would not have been found with traditional approaches about, I think this is relevant and I'm going to test it. We have seen just entirely new concepts brought forward that I think would, maybe never have occurred to people before we had these unbiased, hypothesis-free approaches. So it's a really exciting time, and I think that we have many more discoveries coming down the road.
Yeah. I also wonder, COVID changed the way that we communicate as professionals, as human beings. I mean, I've said to people, I loved going to conferences, not, assuming I'm not presenting, but what I really loved was the corridor conversations over a coffee or a beer, where you'd meet a colleague. You might talk about sport, you might talk about, family and professional achievements, but you could kind of test ideas and convey ideas. That stopped. We kind of mutated into this online world. And I have certainly found nowadays the Zoom meetings stack up. There's not even any time to go to the bathroom, for goodness sake. So I wonder if the speed of communication has actually helped the interchange of ideas and has made it possible. For instance, you're on the west coast of the United States. I'm in London, and we can have a sensible conversation. What do you think of that? And the flip side of that was just reading an article all about the growth of paper mills and fake publications. And this is apparently a massive problem in medical publishing. So, a bit of an unscheduled question, but go for
Sure.
it.
Well, a lot to unpack there, and I think that the COVID experience and the kind of the Zoom generation we've entered in really has cut both ways, as you pointed out. For sure, the ability to spontaneously interact with people across the world, free of charge, has really enabled the exchange of ideas. But I think it's also desensitized us, and you end up on these larger meetings where people are not as engaged as they would be in person. Just this weekend, I was in Chicago for an American Heart Association meeting. I'm from Chicago, and we had this marvelous dinner where we took out people from all over the world. It was their first time having true, honest to God, Chicago-style deep dish, and that evening
For
was just
anyone who doesn't know, you got to tell them that's the Chicago interpretation of pizza.
yes,
Yeah.
yeah. Well, there really is no other. I think we can all agree on this.
Oh. We have some Italian listeners who I think would disagree with you, but anyway.
But the point is that we had this wonderful evening, and that camaraderie and the ability to exchange ideas in a personal format is irreplaceable. And so I think that while Zoom has been enabling, we absolutely need to get back to the point where we can meet and have these wonderful discussions that academia used to be so heavily focused on.
Yeah, and the publication issue, the question of publications, how do we as
Yeah.
doctors, I think we've got to speak up about it, frankly.
Yeah, that's a real concern. I sit on the editorial board of a couple of journals, and the rigorous journals I think have maintained a very high quality, a very high bar. But there are predatory journals. There are ones that are using Chat GPT to synthesize text. I think that we are really in an uncertain time, and I think that this is leading to the publication of results that are not always reproducible. And I actually don't know how to handle it, but I think that this is really emphasizing the high quality journals, the role they have to play in the rigorous peer review, the replication of findings, and the dissemination of them widely. I don't think there's too much worry about things bubbling up from the paper mills overseas, but it is something to keep an eye on, particularly as the generative text programs become more and more effective, and it's hard to really tell those apart from honest to goodness research.
Yeah, a friend of mine here in London had written a letter to the editor about an article about the role that AI would play in medicine. And he wrote the response. I'm going to be careful what I say there. And he stated in his letter, just to show how good this stuff is, I'm going to write my response as if it was spoken by a fairly well known American politician who might be running for president. And it was scary good. But anyway, let's move on. Your translational work involves leveraging human genetics, as you've hinted at, and advanced immunology approaches to discover new cardiovascular therapeutics. Tell us a little bit more about this bench to bedside approach and how it's going to lead to innovative ways of addressing atherosclerosis.
Yeah, I mean, we really have taken this philosophical approach that we only want to pursue lines of reasoning where nature has already done the experiment for us. And this is what I meant about moving from hypothesis driven to unbiased research, like we did in the old days, to where we're moving now. Um, because we have these incredible biorepositories and we have high density genotyping, we can scan the entire genome, we can now very clearly identify genes or pathways that are associated with things that we know are relevant, like cholesterol, like longevity, like having fewer episodes of heart attack or stroke. Once we have identified the genes that are associated with those, there's still a lot of work to do to explain how they work and how to drug them. But it's so nice to know that while we may still confuse the mechanism, there is really little doubt that a gene plays some type of role in the risk or prevention of these individual diseases. Once we have those, we do the hard work of making knockout mice or other models where we can see the effect, see how the signaling occurs, develop a system where we can test new therapies, bringing them forward. In my case, it just so happens that many of them end up being inflammatory or immunological in nature, and that's why we've gravitated towards that approach. But you could imagine a scenario where a different modality is used in other disciplines. The reason I think this is so powerful, though, is because it's now been shown that drug development targets that are genetically informed have more than a 2 times higher likelihood of proving efficacy in phase 3 trials and then making it to the clinic. So this will de-risk drug development, which is incredibly expensive. It'll make it more likely that the investment from the NIH and others that's being put into new medicine discovery will actually see the light of day and turn into new medicines that can save lives and improve quality of life. And we just think that it's so wonderful when the nature has already shown us the roadmap of what's likely to happen, and then all we have to do is follow the breadcrumbs and make it a reality.
You make it sound very, very easy, but it was an eloquent answer. And I guess let's drill down into some real world examples, you are a bit of a rarity. Now, you are at Stanford, which has a reputation of producing and supporting some folks who really do understand the continuation of bench to bedside. And when you and I were chatting, people like Josh McCall, people like Tom Fogarty, who've been, paradigm shifters in medicine. And I've had the joy of helping take some med tech from mind to marketplace. And once over the hump of concern that research outside of a university lab is not the same, and learning that it can actually be faster, more cost efficient, more effective, and it can also be enjoyable because you're not dealing with a massive bureaucracy. You have co-founded two biotech companies that I mentioned, 47 Inc. and Bitterroot Bio, and I'd like you to individually uh, take us on the journey about how you founded each, what each is doing, and what you hope to achieve with them. And by the way, congrats for doing it, because I think academic researchers and clinical researchers somewhat abrogate their responsibility. They know the science best. For goodness sake, hang on to it, help develop it.
Yeah, so I think that you're spot on about all of your observations about the, bench to bedside translational journey. We talk a lot, as you know, about the so-called valley of death, where you can have, beautiful observations in the ivory tower in academia. You can de-risk them with genetics and beautiful causation studies in mouse models or what have you. But then there's this very real and very long period where many things will, die on the vine, where they cannot get through the very critical stages of early drug development and then through the clinical trials that are necessary to prove safety and efficacy. And it just turns out that some of the best scientists and academicians and physicians that are leading our universities, as brilliant as they are, we often are not really equipped with the skills and experience necessary to make that transition through the valley. Turns out we're often not very good business people. We're not very good at fundraising or working on intellectual property rights that are necessary to secure this. We often have very little understanding about what a real rigorous clinical development program and clinical research program would look like outside of what we do in our academic environment. And for sure, we often have very little experience with the regulatory interactions with the FDA and others, how to make these medicines in a safe and highly regulated environment. These are things that you just can't get exposure to through the traditional medical school experience. So I think that it's critical for us to acknowledge those weaknesses and then find people that can help us get through that valley of death. And as you point out, we need to stay there with them through the journey because we've often helped discover the science. We may have some insights that would prove valuable, but we need to build these teams that have those skills. And as you say, I have just been delighted and surprised to find how enjoyable and how fast these organizations can move. And it's a little bit different. I mean, there's a sense of camaraderie. There's a sense that we're developing these medicines to actually get them into people. And while there's nothing wrong with curiosity and discovery research in the ivory tower, there's something very fulfilling about working on a medicine that will get into patients one day, where we can test the hypothesis and see if we're correct, and hopefully one day have a medicine that's safe and effective.
Yeah. There's an old joke that, why are academic politics so unpleasant? And the answer is there's so little at stake, right? I've actually just come from a meeting with some people developing evaluating a new medical technology, and spent a day and a half laughing largely with some lovely and very smart people. And the key thing you mentioned there is we don't know about fundraising. We're not good at this. We're not good at that. That's where we discover the concept of a team, and you bring in people who do have that. And for any potential medical entrepreneurs out there, you don't have to be the CEO. You can develop the technology and bring in someone. Being the CEO sucks. It's it's not a great job. The title means you execute the mission of the board and can be fired quite promptly. So anyway, tell us briefly about 47 Inc. and Bitterroot Bio, specifically what they do. Just an elevator speech for each.
Sure. So 47 was one of the recent waves of immuno-oncology companies, and unlike what you might hear about with CAR T cells or other checkpoint inhibitors, this group took a different approach, looking at the macrophage instead, trying to teach those cells how to not be immunosuppressive, but in fact how to rev up their ability to go after and remove the disease cancer cell. This work was really spun out of the legendary scientist Irv Weissman, who's my co-founder on both companies, probably one of the finest scientific minds I've ever come across. And he really just beautifully put together one of these teams and showed me how it was done, how to secure funding, how to rapidly advance this through all of the non-human primate trials and things that, again, wouldn't occur to me as a head in the cloud academic, and then get them into clinical trials. That company has been acquired, and these are now, you've handed off the reins to a larger pharmaceutical company who has the resources and experience to put these through large phase 3 trials. And we'll see how these medicines do. I think that in Bitterroot, we had a very similar experience where, again, I was able to return from my divergence into the oncology arena back to my home in cardiology. And here we are again using human genetics to inform new anti-inflammatory and immunoregulatory therapies, where our goal is to actually begin to melt the plaque away and prevent the buildup of the lesions that cause heart attacks and strokes. So you can think of us as kind of Drano for the blood vessels in the heart. And so far we've seen in our mouse models that not only can we slow down the progression of disease, we can begin to melt it back away and induce regression. We've shown good quality safety data in our non-human primate studies. And just 2 weeks ago, we began our first in man human studies where we're testing our new compound for the first time in human beings. And that's a very fulfilling and satisfying experience where we're getting to test the hypothesis and see if we're right. We have a long way to go ahead of us. We'll have to go through proof of concept studies next. But it's just really enjoyable to think that things that we were discovering in the laboratory will be tested in humans. And this is just the first of many new therapies that we hope to bring to bear to reverse cardiovascular and metabolic diseases, which, as we mentioned, are the world's leading killers.
Well, when those studies are underway or you've got interim results, let us know. Come on here and talk about them.
Thank you.
So, you've had extensive involvement in organizations like I mentioned, the Society of Vascular Medicine, American Heart. Can you discuss some of the key initiatives or projects that you're proud of that have made a difference in cardiovascular care? For those non medics listening in, we have these professional medical societies at which we present our research, share ideas, have collegial interactions, look for jobs for our juniors, talk about political issues. But we do sometimes try to do things that will actually change the way medicine is practiced. So the floor is yours.
Yeah, no, I think these societies play a very important role, and they often have very wide-reaching and ambitious goals. The American Heart Association is engaged in advocacy and lobbying and physician education, patient outreach, patient awareness, and they do all kinds of things that each advance the field and improve the quality of life for our patients, the awareness. They raise funds for this. But as I thought about this interview and what's the real role of these societies, to me, it's actually a place uh, to provide a home for people that have similar interests. It's a place for people to convene. And as I mentioned, having Deep Dish in Chicago last week, it's a wonderful place for young investigators in particular to come together, develop friendships, develop networks, and establish collaborations that may not otherwise occur at their local university or their own individual institution. I think to this day about some of the people that I came up with through the American Heart Association or the Society for Vascular Medicine or the Gordon Research Conference, and just these wonderful relationships. People from all walks of life, all over the world, different disciplines, different scientific approaches, but together we are able to form ideas and figure out how to tackle problems in ways that probably would not otherwise occur. And so there's a real sense of camaraderie and common purpose. And so to me, that's the most important role that they have is, really to convene people who are working on the same problem to cross pollinate and think of the best ways to advance the field. So that's why I continue to go. That's why I support them. And that's why I think they're so fun.
And have you got anything in the offing that you can tell me about, or is it you'd have to tell me, but then you'd have to kill me, like new initiatives? I mean,
Oh,
I'm
in
a
my
big fan of, yeah, of you personally. I'm a big fan of prevention. I don't think we do enough to prevent cardiovascular disease.
Sure. I mean, we're very focused on therapies, but we agree that there's an important gap that needs to be addressed about diagnosis and prevention. My personal laboratory right now is incredibly focused on the intersection between heart disease and cancer, which have historically been viewed as kind of distinct entities. But
Well,
you know, we,
we're going to come on to that. I want to
sure.
separate that out. But yeah, I'm sorry. I didn't mean to. Well, I didn't mean to interrupt you. But
No, it's fine. It's fine. But I think that breaking down these traditional silos has been really one of the most exciting things that we've started to focus on. And while of course we're still trying to advance our immunotherapies and new genetic targets and even some new lipid targets, I think trying to consider medicine through a new prism, kind of a unifying diagnosis or a unifying hypothesis, has been very enjoyable. And I think that's where we're heading.
that's a really great point because traditionally we've existed in these silos. So, for instance, when I trained, I spent a lot of time learning how to do a whole range of operations to treat peptic ulcer disease. And then some Barry Marshall et al. In Australia discovered that there was a bacteria that caused it. And they took all that work away from us, which of course is fabulous and it's in the patient's best interest. But peptic ulcer disease went from being treated by gastroenterologists to surgeons to infectious disease doctors. There's nothing wrong with that. That's the part of the genesis of our profession. So, given your expertise in vascular research, what emerging trends or technologies over and above what you've already talked about with immunology and genetics do you believe are going to shape the future of cardiovascular medicine, particularly in the prevention and treatment?
Yeah, well, I mean, not to sound like a broken record, but I just have to come back to human genetics. If we were satisfied with what we already had, like statins, for example, Lipitor, Crestor, things like that, we can absolutely get a 30% reduction in heart attack, stroke, and death. This has been one of the most, transformational type of medicines ever advanced for any field, and it will remain the standard of care for decades to come. But people have said, well, I wonder if we can do better, and I wonder if we can learn from the people that are out there that have surprising phenotypes. Who are these people that have very low cholesterol levels from birth, that have essentially almost no risk of developing cardiovascular disease? What can we learn from them? And so I love, the examples of things like what Helen Hobbs did at UT Southwestern, where she took cohorts who had very low cholesterol levels and did genome sequencing, and said, "Aha, there's this new enzyme that we don't know what it does, but it clearly has a role in lipid metabolism." And as you are aware, this led to the discovery of PCSK9 and the rapid translation of new therapies, both antibody-based, also siRNA-based, and even genome editing is coming. And now we have these medicines that can reduce lipid levels to values that we never deemed possible before. And accordingly, we're seeing improved outcomes directly related to that, not only for heart disease and stroke, but also my clinical interest, which is PAD. We're able to save not only life, but limb, and we're avoiding amputations in these patients who really before then had no opportunities or options. We're seeing other examples along these lines, and I'm working with a really exciting RNA interference company this year called Arrowhead. They are going after additional lipid targets that can now address triglycerides in ways that were never possible before. And so I think if we stay tuned, we're going to see more and more of these kind of surprising discoveries that are enabled by very carefully studying cohorts of individuals with rare diseases or even large populations that have subtle genetic effects, and that's going to keep moving the needle. In my particular area of atherosclerosis, we were shocked when they did the first genome-wide association study where they looked across all 3 billion base pairs. It turns out that by far the head and shoulders top genetic locus resides in a tumor suppressor gene, not in a cholesterol locus or a blood pressure locus. And so, this kind of observation is going to make us say, well, gosh, I wonder what on earth is this cell cycle regulator that we always thought of as regulating mitosis and cell division? What on earth is that doing to cause heart attacks? But now we can go down that route, we can pursue that pathway, and then I think you're going to start to see more and more advances, many of which are hard to even contemplate at this point in time, which is part of why it's so exciting.
Yeah, well, that's a perfect segue. We've already discussed that cardiovascular disease and cancer are the two leading causes of death worldwide. And you gave a TED talk in 2021. You explained the biological origins of these two diseases are not that different, and you've now hinted at that. Can you tell us a bit more about the genetic and inflammatory factors that link the two diseases? I remember hearing at medical school that if you've got a chronic venous ulcer, the chronic inflammatory process is pre-malignant. If you've got Barrett's esophagus from exposure to the peptic environment, it predisposes to esophageal cancer, and on and on. How this link could facilitate the development of dual therapeutics and obviously help us with diagnosis and prevention, which of course is the real pot of gold at the end of the rainbow.
Yeah, no, for sure. I mean, as I alluded to earlier, this intersection between cancer and cardiovascular disease has really been on our radar for a while. It's long been known that, people with one disease seem to be at higher risk of the other. This has always been kind of explained away by shared risk factors, like smoking. If you smoke, you're equally likely to get lung cancer and have a heart attack. And that was pretty intuitive. And to be fair, for a long time it was hard to tease out confounding. How do you know that this isn't pleiotropy where the same process is affecting both diseases? But our genetics and other types of informatic capabilities have gotten a lot better, and now we can integrate genomics and transcriptomics and other layers of kind of large data sets from patients with both types of diseases. And when we do this, we're starting to find common pathways that seem to be causal for both diseases. I mean, in fact, you can put these things through the algorithms, and then they actually have a hard time distinguishing certain different types of cancers from different types of atherosclerosis. So, the overlap is significant, and we have a long list of targets we're going to go after. The ones that have jumped out to us, as you point out, are really about inflammation and the inability to resolve inflammation. And we think that, of course, this is going to induce the recruitment of inflammatory cells to the diseased blood vessel. And that's a very key factor underlying plaque vulnerability and risk for plaque rupture and heart attacks. But this is also a problem that's occurring in malignancy. And so, as we really drill down on the shared pathways, our hope is that we can find medicines that could treat both diseases. And what I'd like to do one day is develop a kind of a survivorship concept where we can say, well, you've had cancer or you've had heart disease, and we now know from your genotype or your profile that you're at high likelihood of developing this other type of cancer or other type of cardiovascular disease. And we can probably intervene on this and reduce that risk, or at a minimum, enhance our screening for it to detect it early if it should occur. So that's where our lab is going, and I think that these are tractionable. I think that we can develop medicines around this, and I'm very optimistic for the future.
Of course, the one issue, as always, is going to be access to care and paying for it. That's the big thing. And everyone I talk to on this podcast, wherever they are in the world, it's always how do we fund the research? How do we provide access to everyone if we believe, and I'm sure we do, that health is a human right and it's aspirational that we should do the very best for everyone in this world. Amazing. My final question, my dear chap, I ask every guest that comes on here, if a magical genie could grant you 3 wishes in your area of expertise or anything, quite frankly, they're your wishes. what would they be?
Yeah, that's a great question. I think the first thing that we need to do as a field is to restore humility to science. I think that we need to get back to a point where scientists have a dogged but dispassionate attitude towards scientific discovery. I think one of the real sins of COVID was that we lost our ability to uh, be challenged in our hypotheses. And in fact, we went so far as to skew the other way and to vilify and denigrate or even censor those who would seek to challenge our worldviews. And I think that was a real mistake. I think that scientists need to be above the politicization of medicine and scientific research. We have to always be willing to have our hypotheses challenged and to not become emotional if we're proven wrong. I mean, that's actually the whole purpose of science is to pursue truth through prospective, randomized, and placebo-controlled research. And I think that we need to get that back if we want to get the trust of the public back, which I think was lost and deservedly so. And so I think a lot about what happened to Galileo, and I'm really sad that we have to learn this lesson a second time. But I do think that that's one thing that I would argue would be very important for us scientifically. The second thing that I would say is that we need to double down on our investment in young scientists, and think about ways to enhance the number of small grants that are given to junior investigators, so that they have that chance to have success in science and academia. It's well known that many of the greatest discoveries of all time happen when people are in their 20s and 30s and maybe their 40s. I think that at some age, it becomes difficult or impossible to resist dogma. And so I think that we need to have the NIH and the American Heart Association and others really double down on funding smaller seed type grants for young people to give them that chance. And then I think the third thing I would say is that we have to just break down silos. And I think about all of the papers that I've worked on or published over the years, and which are my favorites, if you will. And I think that the best work we've ever done is the stuff where it's not just me and a bunch of other cardiologists. It's always the best when we have different perspectives and diverse viewpoints from different fields, and get the engineers and the geneticists and the chemists and the mathematicians involved. And that's when really beautiful science tends to emerge. So I think that we should move away from kind of organ-based research or disease-based research and say what's the big problem, and who could we get in this tent to help us work on it. So those are the three things that I would say if I did have a magic genie.
Well, beautifully said. I think the first comment I would make is I'm reminded of the tale of two doctors sitting in a very large conference room that's packed, and one whispers to the other, how many truly brilliant doctors do you think there are in this room? And the other guy says, one less than you think are here. Right? I'm a huge believer that we should aspire to be wise and humble and not arrogant and ignorant. And I concur that, and it's not just in science; it's in life that people seem less capable of disagreeing without being disagreeable. Um, and as we were talking earlier, a multifunctional approach to science. The wonderment of a child looking at something that they see for the first time, and if you could capture that. Um, I think if we could capture that and disseminate that, wouldn't that be amazing? So I just want to thank you. You're a very, very good communicator, as well as obviously being a very good scientist and clinician. I'd like to thank Dr. Nicholas Leeper for being with us here today. Keep doing what you're doing, because we've got a lot of disease to cure.
Thank you so much. Really enjoyed this.
So, folks, please subscribe so that you never miss an episode. Like us on social media, write nice reviews, say nice things. If you have ideas of things you want to hear about, write to us. I believe you can DM us, which I'm still not entirely sure what that means. And tell your colleagues, and check out the archives, because there's some wonderful, wonderful episodes in there. They've certainly delighted me as the host of this program. And please join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sakia. Thanks so much for listening to the EMJ podcast. Please stay safe, stay well, stay curious. Bye for now.